the first conversation we have is, what would you like to achieve here? Weight loss the right way is not just throwing one of the novel medications at someone and saying good luck. Patients often find that their eating is just happening.
How do you even tackle that?
So we've been able to lower the amount of effort to stop eating.
I don't know a lot of people that have breakfast, lunch, and dinner.
And that's celebrated.
I'm Dr. Beatrice Seguin, PhD, and you've landed on my podcast this time of the month, your trusty sidekick to the midlife roller coaster. I chat with experts digging into legit solutions for midlife hurdles, be it health or lifestyle. Ready for the ride? Dive into this time of the month. Subscribe and catch the latest episodes on our channel. Let's own this midlife magic together. This episode's going to change the way you think about dieting. Dr. Ashley White shares how important it is to know yourself and what you want before you even begin to think about your weight management. Tune in to learn more about the harmful impact of diet cycling. Goodness knows we've all been a part of diet cycling, trying the latest fads. In a world full of people trying to tell you there are quick fixes, the truth is there aren't. But if you watch this episode, you'll see there's hope and there are things you can do to feel better. Dr. Ashley, welcome.
Thank you for having me.
This is such a huge topic.
Yeah.
I just want to start with, why does weight or the lack of losing weight feel like such a failure for women?
Because most women, and I think this is true for a lot of people, but it is especially true for women, and it's especially true for women in midlife, believe that most things are under their control. And with enough willpower and enough determination, they are used to things working out. They are used to being able to exert a certain amount of effort and achieve something. The issue is that weight is not completely subject to our conscious control. And we live in a society where every message from every media is that if you would just do things differently, you would be able to achieve the result that you're looking for. Mm-hmm. And in fact, you and your efforts are the problem. And that's not true, but no one's been offered an alternative, or it's rare that people have been offered something else. And so people are left in this place of assuming that they are the problem, continuing to demonize themselves, right? And to criticize themselves for not being able to do this, to lose weight or to maintain a weight that they want to be at. And that lets people, or it sets people up to feel like failures. And we are lucky to be living in an era where things are going to change very quickly, but I don't know that our health system is ready to live in that very nuanced gray space that you have to live in to help people navigate weight loss the right way.
And what is that way in your view?
So weight loss the right way is a very personalized approach, and it has to be driven by the patient and the patient's expectations. So weight loss the right way is not just throwing one of the novel medications at someone and saying good luck, which is basically what our system has time and capacity for. Mm-hmm. It's about tapping into the patient's value set, what intrinsically motivates them, what will allow them to sustain an effort that they can handle for a life of ideally fulfillment, and how can they employ tactics that work for them and that they choose in a way that allows them to meet their personal objectives around health. So it's really a longevity question. It's a transformational approach to determining how weight loss works for you, mm-hmm. which is why diets are so oppressive, because they don't factor in so much of what we identify in clinic. When you start listening to a person's story, male or female or any gender, when you start listening to the story, you realize that the origins started sometimes in utero, sometimes many generations before, and people are navigating they're navigating a cellular experience of hormone signaling, peptide signaling, environmental signaling between the microbiome and the external environment, emotions. They're navigating trauma that's manifesting in a way that they're not even sure how to experience. The people are eating and navigating an appetite that is being that is being controlled by something they can't perceive.
You just said so much in there.
Yeah, I know, sorry.
No, this is really good.
Yeah.
Can you take all of those
Yeah, yeah.
and unpack them for us?
Sure. So, for example, if a patient comes to me, right, the first conversation we have is, what would you like to achieve here, right? Most of the time they say, I want to lose this much weight. I want to be this weight. So the first layer of the onion is, you want to be that weight so that you can do what? See what? Live in a way that allows you to what? And we call that the life weight, okay? So a lot of times people come in and they have the idea that the weight that they were when they were 21 is the weight they would like to be at. And typically that's an unrealistic expectation. Depending on where they started, and everyone's different, often that is not a realistic expectation. And so we have to decide, well, where do you want to live? And what does life mean for you? Because the assumption that people come in with is that when I achieve that weight, then my life will begin, or my life will be back to where I think it should be. And those expectations are typically actually not connected to a person's inner experience. When we peel it back more, people are looking to heal. They're looking for recognition, they're looking to be seen. And so we start really asking questions. What is your appetite like morning, noon, and night? And then from there, a lot can be revealed. We will typically start seeing patterns that indicate insulin resistance, even in non-diabetics. We will also start seeing sleep disturbance. Sleep disturbance allows me to start asking questions about trauma, which I find all of the time. And sometimes that trauma is an actual, a very difficult event, either experienced by the patient or vicariously, or the trauma is emerging from an environment, a developmental environment, a childhood environment that is negligent, that is invalidating, that says, particularly to women, but certainly to everyone, your value is your body. Mm-hmm. Your value is being silent. Your value is making sure that everyone's needs are met, except for yours. And then lots of people have much worse developmental environments. So their appetite the formation of their appetite occurred in that environment. So they've learned not to listen at all. And patients often find that their eating is just happening. They don't know why. They don't know when. They're just trying to manage. They're just trying to handle it. There's a lot of noise. A lot of cognitive real estate is devoted to how am I going to get through this day without eating in a way that makes me feel unwell or that makes me feel like guilty. Or shame, mm-hmm. right? How am I going to eat in a way that allows me to belong in the world? Once we start unpacking actual biochemical diseases, so we're seeing lots of prediabetes, insulin resistance, we're seeing a lot of perimenopausal hormone disturbances that aren't manifesting in obvious disease, but 1/3 of the month, my perimenopausal patients are like, I don't regulate my emotions very well. Yeah. And when I do that, it causes a cascade of conflict in my home. And that causes a cascade of feelings of low self-worth. And then that makes me feel excluded. And then my appetite from there sets me up for binges, right? So oftentimes we're not dealing with full-blown binge eating disorder, although that certainly is something that...
Can they develop later in life?
Oh, yeah.
Do you see that in
pretty much
perimenopause?
anything can develop at any time.
Yeah.
But normally binge eating disorder would not develop post-menopausal.
Right.
Typically.
Mm-hmm.
Binge eating disorder is probably on a spectrum of manifestations of PTSD, probably, because it's a dissociation. Mm-hmm. It's different than just overeating. We navigate that. We really try to parse the hairs on this kind of stuff, because it really matters. The actual therapeutic intervention matters. The reason I started the clinic is because when you have conversations with women about this, it takes hours and hours and hours. And there is nowhere in our system that you can go to have all of these conversations about diabetes, about vascular risk, cardiac disease, stroke, about weight, about pelvic and sexual health, about appetite dysregulation, about psychiatric illnesses, about nutrition, micronutrient deficiencies. There is no place for that.
There's nowhere.
No. And endocrinologists aren't going to do it. Cardiologists aren't going to do it. Family doctors do not have the time or capacity to do it. Surgeons are certainly not doing it. They are very devoted to the procedure of gastric reduction or whatever procedure you want to have. So I said there needs to be a space where people can come and say, what is happening to me? Like, I don't even know who I am, and my energy is directed at trying to make alignment between who I think I am and who I see and who the world sees when they look at me. And we try to very much parse apart this body acceptance work from the work of weight loss, because weight loss, there's a scientific basis to it. If you can really do a proper assessment, it's not difficult for me to say, okay, here are the 4 or 5 physiologic issues, right? Here are the 4 or 5 mind-body issues. They're not ever entirely psychiatric, I find. However, the effort that you, and so I can do all that, and we can treat it, and we can modify it, and we can reduce the impact, right? But that doesn't mean that when I pull away all of that, the weight will certainly come down. But if you're looking for weight loss to bring you belonging or acceptance, it won't. It just can't. It can't.
You have to address the source.
So you also have to be doing that with proper guidance while you pursue changes in your body. And it's okay to want to lose weight. It's considered like taboo these days.
I think the whole subject right now it's a mix of taboo with contradiction, guilt. You're guilty if you're trying to lose weight. You're guilty if you're
we have on one hand, our system is very imbued with healthism, which is like if you are not pursuing health, then there's something wrong with you, and if you are not pursuing thinness, specifically thinness, then you're not working hard enough, right? That is built in, right? At the same time, and for completely understandable reasons, there's the emergence of a phenomenon where people are saying, listen, at some level, we just need to accept that there are an array of bodies out there. And there are an array of bodies that are beautiful. And that's important. It's important that that movement emerged. But now we are in a place where, and that movement also was deeply influenced by the fact that we didn't have excellent tools clinically to offer people to help with appetite regulation. We also didn't fully understand a lot of the psychiatric phenomenon, like binge eating disorder and eating disorders, in a way that we have a lot better understanding of how these things work. So this movement emerged from this like very rational place, and lots of people have found a lot of self-love in that space, and that's important.
Yeah.
But now, A, we have therapies that work, and B, we are being slammed, and I know this because of my work in sort of traditional medicine, slammed with liver failure, massive vascular risks. We are being slammed with people who will not have healthy pregnancies because their body is so inflamed and so dysregulated as a result of the organ of fat. So fat is an organ.
Carrying visceral fat.
And it's not that the fat, it's like all fat is bad. That's not it. It's that fat is active. It is biochemically alive. And all of the signaling that your body does to control the 5 bajillion different processes that happen in it, without our even awareness, fat influences how we do everything. It influences the entire milieu of our body. And so it's really important that we have the right amount, but it's also really important that it's not got a mind of its own and totally it's not affecting our ability to live our lives.
So I think you're saying, are you saying that now it's almost not okay to talk about if we're carrying too much weight? That is not healthy. Like it could lead to.
Everyone is different, right? There are people who are in larger bodies who really don't have a lot of disease. There are people in smaller bodies who have a surprising amount of disease, metabolic disease. And the reason that we miss it, we just don't see the forest from the trees.
How do you know?
You gotta really know people.
Yeah.
And our system is not set up for that. We have a bunch of people who are, they're not medical doctors. So they're in the realm of, they're allied, right? So they do have very specific and useful knowledge, right? But they're not able to understand the role of a lot of the biomarkers, understand the role of the imaging findings, understand the stories that people tell when they're suffering from certain diseases. There's pattern recognition there. And you need to actually be elbow deep in the work of clinical medicine to see some of that stuff. And you need to have experience with this sort of broad array of problems that people come with. I think one of the reasons that medicine for women has been so poorly developed is because when women experience patterns of these sort of conditions that are common in menopause, they're telling a story about what they're experiencing, what they're feeling, and the people receiving those stories, they can't identify with them because they don't have the parts, right? They don't have the same signaling, and so they're just like, well, I don't know what that is. Must be fine. Must not be a thing, right? So the story that people
exercise more, try to relax.
It's just your weight. It's just your weight. Weight bias is very real. Yeah. So when I talk about all that stuff, patients are. I mean, it takes months and months and months to talk about all of that, but I have a 6-month sort of block by block, week by week. We ask a couple questions at a time. We gather certain pieces of data at a time. We try very hard not to overwhelm people, but we know that there could be 150 data points that are required to put in parallel with the story patients are telling me. And then at some point, like 2.5 to 3 months in, there's like this moment of, oh, I'm really seeing it now. I'm able to make sense of patterns that I've had for a long time that I blamed myself for, but now I've finally been able to modify them, and not with like hardcore effort or willpower. I don't tell my patients what to eat. I don't tell them when to eat. I don't tell them how to move or when to move. I guide them through a process of making those decisions for themselves and show them when they've chosen certain tactics, when those tactics need to evolve. And how will they know that they've reached their destination? How will they know when they're on the right track?
So if someone comes to you, what's that first step? How do you even tease out, say, you've talked about, the cycles, everything, this psychosocial, there's physiological, but how do you even tackle that? What are some typical things you look for? How does a person discern, is it a metabolic issue for me? Is it how do you do it? Walk us through that process. Yeah.
For your audience, the common pattern is, I'm here because of my weight, right? So I want to lose weight. And that's like, okay. But then it's like profound fatigue, right? They're like, listen, when I had the kids at home, for example, I was like going, I was moving, I was going here and there, I was working full time, I was like, go, go, go. And what they're talking about is like complete survival mode and automatic, like, I don't have a choice, I gotta go. But now, like, I thought I would have all this time and I don't have any energy. And their fundamental problem, the problem that they're actually asking for help with, and they may feel guilty for asking for help with this non-weight problem because they're supposed to be working on their weight, right? Everyone's supposed to be working on their weight all the time. They may feel guilty for asking about this fatigue. And they're guilty for asking about, I just don't have any motivation. And the story that they're telling is often one of like a perimenopausal, it's not a true clinical depression, but it's a perimenopausal like flatness.
Yes.
And that opens up this like box of questions in my mind. And I don't throw them all at people because it's like, I don't know what to do with that, all that. But the patients don't, they get overwhelmed. But I just ask a couple, and then a few ideas emerge, and they tell me a story. And often it's a story that I recognize in the last 24 patients, right? And I say, okay, I'm gonna sit with that, and I make a note of it for later, right? I don't throw people on typically more than one medication at a time for sure. And then over the first 6 weeks of the program, we build out like, this is an area that you've identified as a problem physically. This is an area you've identified as a problem. And it's just through like hours and hours with a patient of just talking with them and hearing and listening and saying, oh, I wonder about this, and then asking a question about that, and something that they say just tweaks something where I'm like, interesting, tell me about that. And the version of their health story that I get on day one, not remotely close to the version of their health story I get 6 weeks later.
Who has, I mean, you're offering this. Are you the only doctor in Canada that's offering this? Because everyone's going to want to chat to you. But how does a everyday person living, in these vast
so the reason
countries,
the reason I am launching the online version of the program is so that I can mimic as deeply as possible the conversations that I have. So I've tried to formalize and codify exactly how do I get these stories from people and how do I make sense of them. Part of it is just like experience. I'm in my 8th year of practice, but part of it is also just like paying attention to certain things. So how do I demonstrate to someone who I'm not working directly with how to walk themselves through this process? Because it's relatively easy to find a physician who's willing to prescribe
and we'll
semaglutide
talk about meds in a minute.
and whatever. Yeah. But it's not easy, and I get lots of people who've been on semaglutide for years, and they've lost 5-10% of their weight, which is wonderful, and that could be quite fine. But they're like, but I still don't feel very good. What's going on here? And they still are probably over-attributing their symptoms to weight. They still probably have unrealistic expectations. But also there's all this uncovered stuff. So the online program allows you to find the prescriber, right? Advocate for testing that you should have that is not normally done. Testing for insulin resistance is not hard.
It's not part of a standard routine?
No. You're not even taught in medical school why it could be important. You're taught in medical school that excess insulin is only a problem when someone has an insulin-secreting tumor, which is excessively rare, right?
Right.
But lots of people have insulin resistance, which means certainly just like high levels of insulin in the body, right? But also they're not listening. They're not sensitive to what insulin is trying to accomplish, which means their metabolism is not working. It's not smooth. They're not going to lose weight predictably because the way that they're handling fuel is off. So calories in, calories out for sure. Like you need a calorie deficit, right? But creating a big calorie deficit in someone who has been used to high levels of insulin, high levels of glucose, usually high levels of processed food, not enough protein, not enough fiber, not enough water, will make their appetite rage. And they will respond with hyperphagia or wanting to eat a lot.
Right.
That's why this big fad around intermittent fasting, which has not been proven to result in any better weight loss than any other kind of pattern of eating, is really hard for people who have been weight cycling their whole life and dieting, because the appetite is really uncomfortable with long periods of fasting. And so yes, it might be what your physiology needs, but it can create this powerful wanting that completely erases the benefit of a caloric deprivation or deficit earlier.
That's fascinating. I mean, the whole intermittent fasting thing is, again, people preach for it, against it, works in men, not in women, works in young women, not in older women. But I'm really interested in this whole concept of the appetite portion. Do you want to talk about that? Because I think we're not taught a lot. We you know, calories in, calories out. Okay, the basics of that, but what regulates hunger? Does that change with hormones in perimenopause? You know, this idea that we're trying, I'm doing the same things, but all of a sudden I'm gaining weight.
So historically, the movements around dieting or like weight loss, even intuitive eating, have really thought about hunger as a single dimension.
Yes.
There's hunger and there's fullness, and that everyone lives in like a linear spectrum. And you know, our gallbladder and our pancreas and our stomach are always like just like reading where we are. But it's actually our brain that's reading the signals from those organs. That's number one. And the appetite is not just this one dimension. The appetite is multiple dimensions. So in my work, the construct that I offer my patients, and I didn't know how well this would land with people, but there's this hunger and this hunger and fullness dimension, but then there's also this other dimension of wanting and satisfaction. We eat food for excitement, right? Because we get excited by food, and it feels good. And oftentimes when we are not satisfied, there's something, there's an unmet need, then we can use wanting for food the same way we use wanting for sex and wanting for drugs and wanting for alcohol. We can use wanting for food to give us some sense of fulfilled desire, even if the thing that we're using will never and can never meet the need that we're asking for. So if we're in a relationship that's really invalidating or a relationship that's dismissive, no food will fix that, but it feels good. So my patients are asked to actively engage with wanting, and then to actively engage with hunger, but know that they're different. And then the third dimension is like an orb that I think about, which is the culture. So our culture is constantly exerting pressure on our eating experiences. If you eat in public, there's a discourse, there's a conversation that happens about what you should and should not be eating. When you're in a larger body, people have things to say.
Yes.
When you're in a smaller body, people have things to say.
You're eating the salad and you're thin. Oh my God, you have a problem. It doesn't matter.
People have things to say about which is like, and so, you know, if you are not really grounded in how you eat and your values around food and your values around how eating is a manifestation of your identity, then you're going to be like, oh, like maybe there is something wrong with me. And we start hearing those messages really young, such that we actually are unable to tell what voice is ours and what voice is this culture. So I name the culture as influencing every single meal. I name wanting, and in fact, I don't demonize wanting. I talk about the appetite as a superpower, because I'm the kind of person, I was born this way, and later I found I have a genetic variant that explains it, who has always had a bigger appetite than everyone else, always. And I have, for a long time, considered that a personal flaw, something that I was constantly battling with. But when I started to understand my appetite as an expression of like primitive genes, like my ability to eat past fullness is a survival advantage in environments where people didn't have enough food. And where I come from a line of like farmers. One grandmother had 14 children. One grandmother had 8 children in poverty. Like they for sure did not eat enough food. And they managed to gestate, conceive, and deliver all of these children. That is powerful, right? That is the human species at its peak. And the appetite, the ability to preserve and hold fuel for another day when you don't have it, wow. Like that is a manifestation of a species that got to where we did. The issue is that now we live in an environment where people, there's no lack of calories in most contexts.
We have access.
Yeah. We have access to a lot of calories that are devoid of nutrition. Yeah, which is a whole other thing. But so once I decided to say, like, all of these things that I had perceived as flaws, I am going to reframe as gifts. My desire in life is not just for food. Like, I'm desirous of knowledge. I'm desirous of bonding. I'm desirous of connection. And that has led to success, pretty much widespread. And anytime I have been asked to pull back, to restrict, to restrain, I feel like I am imploding. I don't feel like I am living values that I bring to the table, which are all about freedom and integrity and exploration, and like that's the stuff that matters. So I know that I attract patients who are like me, who are like, my whole life I've been told that I want too much, that my wanting is too big, particularly if you are trying to be a member of polite society. And I've just invited people, I've given permission to just like reject that whole premise, that your wanting is actually like welcome here. It's possible that your wanting needs some guardrails. You may have a genetic basis of your wanting. And in this environment, that's probably not always the most healthy thing. We can put some guardrails around it. I have no desire to take a weight loss medication and like shut down a person's appetite. Because how horrible would that be? Like, then food doesn't taste good.
And is it a 1 and 0?
No.
For the medications, I mean, like, how does that work?
So there are several approved medication for weight loss in Canada. The one that you've heard of, most people have heard of Orlistat, which is almost never used for good reason. And then there's ones that are hormonal, right? So right now on the market, we have the GLP-1 receptor agonists. And these are hormones. These are brain-based hormones that result in good communication between the gut and the brain. And then in the pipeline, so for development, are medications that are GLP-1 receptor agonists, but also GLP-1 receptor agonists combined with GIPs, and then combined with glucagon. So we're going to see lots of different drugs.
And for our viewer who may not be familiar with some of this, these acronyms or jargon, do you want to?
They don't even really matter.
Yeah.
The acronyms, the kind of hormone doesn't matter. The point is that in your body, the way that you perceive hunger and satiety is hormones are the reason you have those perceptions, okay? So there's 5 or 6 different ones that allow you to perceive fullness or perceive hunger. What we've done with medications like semaglutide and liraglutide and tirzepatide is give you a little bit more of the things that allow you to feel satiated earlier, and that without food. So we've been able to lower the amount of effort you have to exert to stop eating.
Okay.
What I call stepping out of the eating experience. My patients learn to step in, they learn to evaluate while they're eating, and they learn to step out. That is what they do. And the medications, the injectable hormonal medications, and there's one oral, allow you to just make it a little bit easier to walk through that process. It doesn't mean that you don't have to think about it. It doesn't mean that you don't have to put any effort into understanding your appetite. What it means is that it's actually a little bit easier to do the work, which is lovely.
And so it is part of your toolkit to use this.
Yeah.
And, do you have to be on those medications forever?
It really depends. So all of the sort of the answer from obesity medicine is that, yes, when you stop those medications, the data says that weight will go back. But just like a high blood pressure medication, if you take a high blood pressure medication and then you stop taking it, but nothing else has changed, you are going to still have high blood pressure.
Yeah.
And so it's just like any other chronic disease. So for these hormonal medications, if you are someone who has like the genetic basis to your appetite or to your ability to eat sort of large amounts of food, then these medications are reasonable lifelong therapy.
So is there a test? Does someone get tested to determine,
you're
in your
in my
clinic,
clinic,
but not standard?
No.
Because what we see in the media is that it seems to be just a miracle thing that people are taking.
Yeah.
You know,
yeah. The media is
quite
really good
readily,
at augmenting stories of success and augmenting like dramatic stories of failure. The media is really good at giving voice to the extreme.
Yeah.
And then most of us are somewhere in the middle, really. And because these two ends are all we hear when people aren't extremely good or aren't extremely disastrous, people aren't that excited by the conversation in the middle. It's just not as sensational, and we've just become really used to like these kind of sensational stories of either recovery or sickness or failure, and it's actually just like not like that.
It's super polarized. It's like either really it's great, or it's terrible. There's side effects, and I find it's really confusing for people to know how to navigate and to know if that's where they need to start, or do they need to start you know, something like in your program where it's there's a broader conversation.
Lots of my patients do start these medications early on in the process, and then if they do have a desire to come off, we plan for it. I make them aware of the data, but I also make them aware of, okay, well, we have lowered your insulin resistance by managing your polycystic ovarian syndrome, which had previously been undiagnosed. Your sleep apnea is now treated, and you're actually sleeping through the night. Your PTSD has been identified, and you are having a 60% reduction in the number of times you wake up in a sweat at night. Your perimenopausal symptoms are settled by a combination of nutrition therapy, which is huge, and also just life engineering so that you have more time to do everything. We've been able to put brakes on wanting in the following ways that have nothing to do with the weight loss medication. We've been able to accelerate your ability to perceive fullness. We've improved the nutrition status of your body, okay? If you would like to come off these medications, here's what you because I know you now really well, here's what you might expect as a result of that. And then we allow people to make choices. Like I'm never gonna tell someone, yeah, you gotta be on this forever. But I am gonna be like, you're probably in that group of people who you're gonna gain at least some weight after. And maybe that's just fine. Maybe it's fine, right? And for other people, I'm like, listen, we just corrected a bunch of stuff that didn't get looked at. And I can't possibly run a weight loss practice where I just Band-Aid everyone. Like I just can't do it.
No,
like,
I'm sitting here listening to you, and in my head, I'm just thinking, how does this translate to the public health system that we live in?
Yeah.
How does one?
Yeah. That's what I'm trying to really know now. So the way that I've decided to proceed is treat my own little practice, and it's tiny because I'm giving a lot. Treat my own little practice like a lab, where I'm constantly evolving and listening and just tweaking things. Launch the online program so that people can get a really high fidelity version of what it would be like to work with me. Because like so much of my work is just asking the right questions, listening to the answers, asking the right questions, and allowing people to see if they can build out a full, robust understanding of what's going on for them without me, right? But with my ideas and my system. But then work with a prescriber locally, wherever they are, because I don't have a license in every jurisdiction. I have a license here. And then my hope is that by the end of the year, I'm actually training nurse practitioners and physician assistants and dietitians and pharmacists how to do this, because they don't actually operate in the public sector. Like they do in that hospital and physician services are publicly available, but they are non-physicians. And so when I see a patient, it is publicly insured. But the public insurance was never designed to really get to the root of a problem like obesity, which is a multifactorial, multi-system, brain and body. And we are not equipped for brain-body stuff at all.
On any level.
No. So allowing people access to this high quality care is not going to be about just like making my care available to everyone. It's going to be about teaching other providers how to do this. And I believe I can. I believe that that's where it needs to go. And that's why I'm doing this.
What do you tell a woman right now who sort of, you're on a journey, you're on a path, you're developing a program. What does a person who's just trying to manage her perimenopause journey do when a lot of them don't even have access to primary caregivers? For
sure. So in terms of like really concrete stuff, so number one is you're probably not eating enough protein. So most people are dramatically underfeeding themselves protein. So if you want to be eating like 1.4 to 1.6 grams per kilo of ideal body weight, and we calculate that for people, because you want to be able to, whatever protein you're eating, you want to be able to make muscle out of it. Muscle is life. Like muscle is like, A, it's your metabolism, but B, it also makes you feel good. So that's number one. Number two is look at your sleep. If your sleep is really rough, either because you're up peeing all the time, because you have an overactive bladder, you got to get that looked at. Because you're waking up gasping for air, that could be sleep apnea. If you're super, super tired during the day, that could be sleep apnea. If you are dealing with a lot of hunger at night and very little hunger in the morning, that's probably insulin resistance. And figure out what is happening with your sleep.
Can you ask a doctor to test your or can you get tested if you ask for the test for insulin resistance?
I would like to say yes. Yeah. I was a family doctor for 5 years. I like it when my patients come to me with an agenda, because I'm like, this is great. This shows that you're invested. I love it. How can I help? Right? That is not how most doctors are oriented. Most doctors are oriented to like, this is my system. Yeah. And you are going to comply, and that makes you a good patient. But I actually feel like that's just like helplessness. We're building in a system. We're congratulating people for not taking action on their health.
Well, and we have a disease care system, not a health care. Like a lot of what you're saying, that is
get ahead of it. Get on it.
Yeah.
Like take the bull by the horns. It's why people go to providers who really aren't as well qualified, because we are so obsessed with our guidelines. And yeah, like that's important. I'm not gonna poo-poo that work, but like I'm actually trying to help this person. I'm trying to help you, right? And we let our egos kind of really get in the way of that a lot.
So recognizing there's a lot of, we can't separate mental and the physical, you know, we've talked about that, but just let's stick to some of the physiological aspects of weight and how, if I come to you, someone comes to you and they're complaining the belly fat is just can't get rid of it, the back fat, you know, those are the common things that people want to manage. What do we do?
Yeah. So so like 45, 50?
Yeah.
Yeah. Okay. So part of it is getting how much are you eating and when, really? And when is your appetite the strongest? So lots of times this is a matter of, I don't eat all day even, or I eat at 3 o'clock is when I start having food. And then I'll have some food because I'm kind of ravenous. And then I'll have a big, huge dinner. Oftentimes it's like one meal. And then occasionally there's some snacking after. That's sort of like a classic middle-age pattern that reflects just being super busy during the day. And then years and years of this going on. And you're just like, I just don't eat in the morning. I have a coffee, right? And then now with intermittent fasting, people are like, oh, well, that's like the good thing to do. The issue is that you are better able to use protein in the morning. So you're better able to synthesize muscle via the protein that you consume in the morning. You're also more sensitive to insulin in the morning, which means the food that you eat in the morning is less likely under sort of exactly the same conditions to be stored as fat. So that's one thing. The other thing is that when you wake up, right, and you haven't eaten for 10 hours, your liver has decided to basically permit the dumping of some sugar, some fuel into your blood because you've not got any food, you've got to break down some stores. And so then if you don't eat for another like 6 hours, right, your liver is like, okay, here's some more, here's some more, here's some more. And you're gonna basically be relying on your liver to catch up from a fast. That signals to the brain that there's some sort of famine here. There's some sort of need for me to hold back on my metabolism. I'm not exactly sure where the food's gonna come from. It's a bit unpredictable because I'm used to this sort of like 4 to 6 hour daytime fasted fed, like in the morning, I eat, and then by the time lunch comes around, I'm hungry, and then by the time dinner comes around, I'm hungry, and then I sleep all night. That's the cycle that our brain and our organs like. So if you're just never doing that, right, the brain's gonna think like something's up. And it's going to decide that it's going to do whatever it can to store. That also triggers a chronically activated stress system or sympathetic nervous system, and you're gonna have chronically low doses of cortisol, right? And you're gonna have this sort of chronic activation of a stress response that's not meant to be activated all the time. It's meant to be activated like to run away from a tiger or something, right? It's not meant to be dealing with like the day-to-day stress of not eating enough, right? So lots of people come to me and they're like, Doc, I don't eat very much. And I'm like,
and yet they're gaining weight, yeah.
And they're right. Most of the time in medicine, we just say, you're just lying, or you just don't really know, right? But then I'm actually like looking, they're not. They're just eating almost only at night and almost only processed food and almost only from a place of like that wanting. So the food that's often most desired when you're stressed and when you're like feeling like you don't have enough time or energy is like highly processed foods because it's exciting food. Your brain's like, oh, that's comfortable. I like that. It's not like you're gonna crave like bulgur and broccoli. Like you're just like, what?
Yeah, no.
I don't want that, right? Whereas when you actually decide, when you sort of say, okay, well, I'm gonna eat in the morning, I'm gonna eat at lunch, I'm gonna eat at dinner. And sometimes with my patients, I'm like, I don't care what you eat. Just try to eat
regularly?
Yeah,
Is that
like,
the message?
Yeah,
Eat
just
regularly?
have breakfast, have some lunch, and have some dinner.
I don't know a lot of people that have breakfast, lunch, and dinner in my entourage.
Nope. And that's celebrated.
It's celebrated. Yeah.
And it doesn't make physiologic sense. So like intervention 1 seems pretty self-evident. Eat
but it's
breakfast.
not. There are books, there are
I
entire
know,
books
I know.
and movements and influencers
Yes.
telling everybody to fast.
For sure. And I don't, as a person who is a big eater, so I use the language big eater to like kind of like celebrate it and to also just acknowledge that within the spectrum of big eating, there's like binge eating, there's emotional eating, there's night eating. Like we have all these words to describe this concept of like, I'm still eating, but I know that I'm not hungry. And I want to give voice to that. Like a lot of people are really ashamed of like when they eat, when they sort of know they shouldn't. But I'm like, well, not like whatever, right? And the minute you take away its importance, you do it less, number one. And also you acknowledge that like our physiology is just working below our conscious awareness. And it's okay, it's fine. One of the ways that you can give yourself the best chance at the belly fat in particular is to just eat 3 times a day, and then also to consume enough protein. That's where I would start. That's free advice.
Yeah.
And in fact, in my program, I don't have a lot of like really specific food selection rules. In fact, I don't have any.
Yeah, they're very punishing, those types of rules. And
Yeah.
oh my gosh, I have friends who are like keeping track of how many liters of water at what time they drink, and I'm eating this and that, and it's a very punishing is the word I come with.
Yeah, so I do think that, so I encourage my patients to do some tracking.
Okay.
And I sort of put some guardrails around it, but I say it's for a different reason. A lot of times we don't know what we're thinking until we say it out loud, which is why I encourage my patients to journal. And I don't mean like sit in a field with a journal and like, cause like no one has time for that. But I mean like just say out loud the things that you're thinking, either with me or with a partner or with a friend or on paper or into a text message. I don't care. But you've got to say it out loud, and then your brain will be like, oh, didn't know I had that to say, you know? And then I call the tracking essentially just a tool for pattern recognition.
And we've heard this several times for everything, including your own, the symptoms, the hot flashes, and whatever it may be.
Yeah, matters a lot. So that's the physiologic, like, basics. I give away nutrition knowledge for free because you don't, like, me telling you what to do is not worth much, in my opinion, to be honest. Because, like, you can go to anyone who can tell you to, like, eat and consume enough protein. Like, there's a lot of people, right? But there's a reason that what you know is not what you do. That's where I live. That's what I care about. Because otherwise it's just like pontificating nonsense. And
just furthering the guilt. Because it's not because you don't know something. You know
Never.
it, but you're,
my patients know everything.
I know I
They're
should
so
exercise
smart.
more or move my body. I want to say move the body, right?
Yeah.
But what's stopping me from doing that?
My patients know everything.
Yeah. What about, is there any evidence for hormone therapy? We know it's first-line treatment for hot flashes. What's the data?
The vasomotor symptoms?
Yeah.
For weight loss?
What's the data for weight loss?
Yeah, it's
estrogen, insulin, there's a role there.
Yeah,
there's a relationship.
Yeah, so we're talking about people, so for people with PCOS, definitely managing the ovulation, getting the ovulation on a regular cycle matters, okay? For people who don't have PCOS, do
you want to define that just in case not everyone knows?
Polycystic ovarian syndrome is a condition, it's pretty common actually, but about 30% of people with polycystic ovarian syndrome have excess weight. And typically the weight that they have is belly weight. They have usually some thin arms and thin legs, but it's this weight. And this is the stuff that causes damage. And essentially it triggers insulin resistance because there is a lot of confusion in the body about why some hormones are being produced at higher rates. It's a bit of hormonal confusion. And it results in weight that's really stubborn and infertility and male pattern hair growth and hair loss and ovulation that either doesn't happen or happens irregularly. So that's, and then often high cholesterol, acne, there's like this whole suite of things. That's the classic. Lots of people have it, but they don't have this like classic appearance, which most doctors can spot a mile away. When you start talking to people, you're like, oh, that's the problem. Okay. So for those patients, hormones are really important. For the perimenopausal patient, it really depends. So if I have a patient where they're not depressed, they're not anxious, they're not diabetic, they're not micronutrient deficient, but they just don't want to get up off the couch, and they typically have a couple of vasomotor symptoms, like either the dry vagina, or they have the hot flashes, and often it's just like this feeling of, nah, like I just feel crappy. Their serum testosterone, I check, but then I also check their bioavailable testosterone.
Okay, I don't think that happens routinely.
No, and it's a test that is not covered by our province publicly, so my patients do fund it. I give them the choice, right? Yeah. It's not part of my normal intake, but it's something that I add if I'm getting this sense of like, I think we're at the point of potentially considering either a micro dose of testosterone because the point is that I need to get them to build muscle. I need them to feel alive. And for some women, it's just like that plummeting of the hormones that makes them feel terrible. It is not without risk. And it has to be done in a really safe, managed relationship. I don't give testosterone therapy to very many people.
And my understanding is it's not dosed for women. So there's I've seen a lot of controversy again. You know, we don't, there is controversy around the use of it for women.
When I prescribe it, I don't, because I'm an MD, I can prescribe synthetic stuff. I have the ability to do that. Whereas the reason bioidentical hormones, I think, are widely used is because naturopathic doctors are able to prescribe them, and they're the ones who are often doing this. So I still use synthetics, because my patient's insurance will cover them and whatever, but I'm dealing with like little tiny weird doses that pharmacists are like, are you sure? And I'm like, yeah, I just want if I could just like blow it on them, I would, just like gentle. And they're like, okay, well, normally we do like this much. And I'm like, yeah, because that's not the point of what we're doing here. We're trying to get something like physiologic levels of testosterone in a female who now has none at all, right? Who's spent most of their life having some, and now has none and has no sex drive, no energy, losing muscle by the minute. And I'm like, this is a massive health risk, right? And then the estrogen and the progesterone supplementation, I also typically find helpful, right? But I like to balance it. Testosterone, only in a handful of people, really matters when it comes to like weight loss. And it's, if you ask the obesity experts, like, does hormonal supplementation result in weight loss? The answer will be no, but because it's not a straight line.
Correct.
It's usually like makes it easier to change the behavior gets implemented, I feel better, I have a better relationship, I'm eating better, I want to take care of myself. The change cycle is this. It's not this.
Yeah.
And
that's hard because women or people, we're just humans. Humans just want to know this and this, like, just tell me, just get me here.
Yeah. It depends.
Yeah.
And that is why.
That's not a sexy answer on Instagram.
Sure isn't. Sure isn't. But if you want like it to work, you've got to be willing to ask questions, and also to let me sort of say, you know, under these conditions, this is, I think, reasonable to try. How do you feel about it? Here's what could go wrong. Here's what could go well. Sometimes we won't know. What do you think? And patients will say, no, yes. My patients typically have a very strong sense of what they do and do not want. Fine. Like I'm never pushing back against a strongly held value. I'm actually trying to bring values to the front of what we do. And we just kind of navigate the waters from there. That's how we do it. The hormone piece, one of the questions that you sort of thought it would be interesting to answer is like, why are gynecologists doing hormones and endocrinologists are not?
Yes, I did. We had a prep call. We like to chat to our podcast guests ahead of time. And I'm really fascinated. I've actually tried to invite endocrinologists. So by the way, anyone watching and you know an endocrinologist who wants to come on this time of the month, please call us. I am perplexed as to why an endocrinologist does not, we're not exposed to them. They seem to handle one very specific area of medicine, but hormones, sex hormones, they affect our entire health. So why is that? And why do we have to go to the gynecologist, or why aren't they talking to each other?
Yeah, and seeing a gynecologist for a non-malignant or non-birthing reason is like years of waiting.
18 months, I think, right now. At least.
And like, you know, the cancer burden is just going up, and there's limited access to gynecology resources. I feel terrible for, I feel terrible for almost everyone in our system, but the reason that endocrinologists don't do the sex hormone stuff, I mean, there are some endos who are specializing in sex, right? A lot of them are pediatric endocrinologists, but it is honestly because it's just like not part of the definition of what they do. A lot of it is just like...
It's like historical?
Yeah, so it's historical. We didn't really start using hormone therapy in women at a time when the profession, and also it's dominated by diabetes.
Yeah, which is a huge problem. Again, it's not a blame, it's just I'm perplexed.
Diabetes, pituitary dysfunction, either tumors or infarcts, or like one of the million reasons why you know, and like really weird, rare stuff. Thyroid stuff, that's a huge role for endo. And then there are some endos who focus on infertility, right? But there's not a lot of like menopause endos. And honestly, it's just patterning of our system. It's like, why don't family doctors do addiction care when like that's the front line of addictions care, right? Like addictions medicine wasn't a thing 15 years ago, really. Obesity medicine wasn't a thing 10 years ago, right? And like it's certainly, so the reality is there needs to be a specialty of people who are willing to receive this complexity and to, but like there's no compensation mechanism.
I was going to say it's looping back to the beginning of the conversation when you said, well, the healthcare system hasn't caught up.
No.
It hasn't caught up to the complexity of the issues we're dealing with.
No. It's really good for like, oh, you have a heart attack.
Yeah.
Here, let me offer this to you. Or, oh, you have a thing that I can cut out of you. That's why we've relied so heavily on the cornerstone of bariatric surgery, because it's dramatic results that surgeons can get paid well for. That's the bare truth of it, right? Mm-hmm. The work that I do is super, super complex, and the compensation codes for it don't exist.
Dr. Ashley, if a woman's gone through a lot of diet cycling, right? Tried, you know, what was popular in the 80s, then the 90s, then the 2000s, and has she caused any irreversible damage? Like, should we be worried? What do you say to women who've done this?
Yeah, typically I say like most of the time it's fine.
Yeah.
Right. Like you may have to you may need to be a bit more structured about how you proceed going forward, but and also like looking at the root of why were you so vulnerable to those fads? What was going on? So helping protect people from the next one is part of it.
That's a good one. What should we look at? I feel like we're in this phase.
Yeah.
Everyone has something to say and wants you to follow their thing.
I think about, oh my goodness. So essentially, do not take any advice from someone who has not collected any data about you, like your blood pressure, your medication list, your family history, your appetite history, what it was like for you to eat as a child, how many times a day you poop, how much water do you drink. If someone is not willing to make sense of some of that very basic data, the solution that they are offering, usually trying to sell you, which is not bad or good, it's just that's the motivation, is if it works, it's temporary. And if it doesn't work, like that makes sense, right? Because they don't know you. They don't know that actually like you're sleeping like 3.5 hours a night effectively. You're in bed for 10, but you're sleeping for 3.5 hours. If they don't have an answer for how you should proceed, if that's your truth, then they're not prepared to promise you results because they don't understand what's going on fundamentally. When it comes to weight cycling, most people have done it to some degree. We think that when you lose about 30% of your highest weight or your total weight, regardless of how fast you lose it, the metabolism will start to slow a little bit. We'll start to say like, okay, like this is too much.
Protect. Yeah.
So before when I was talking about that, the day-to-day fasting, the metabolism doesn't actually like adapt that quickly, right? There's some like near-term adaptation, but adaptation over like a diet cycle, which is like 6 months to a year, happens. And so if you lose 30% of your body, your body's gonna be like, whoa, right? Your appetite is going to be very powerful. You are going to be hungry, okay? You may have figured out some way to really understand your body and that you can sustain that lower weight and feel good about your life. So great, wonderful. But most of the time, that's not what happens. And so people regain weight, typically more than they lost the last time, right? And then because they had that early success with the last diet, they're like, oh, I just need to find the right
The
one.
new one,
And
the better one,
I
yes.
just need to stick to it. It's my fault for not working hard enough to maintain it. And I grew up in a family that was always talking about diets. Which diet are you on? Which diet are you on? Well, Aunt JoJo's on this diet and Aunt so-and-so's on this diet. And at the dinner conversation, well, I'm on this diet. I can't eat that. You can eat this. Just part of how we communicated. So diets were normalized very young for me in a way. So I started weight cycling when I was like 12, when I wasn't even at my full adult height, which is a dangerous time to be restricting calories, right? But no, we didn't know that, right? So I'm really familiar with this like up-down situation. So your metabolism has probably been preserved. Not always, and it really depends on how much weight and how quickly, and there's lots of questions. But what hasn't probably been preserved is your muscle mass. So when you lose weight, no matter how you lose it, you are going to lose the muscle, right? Muscle is metabolism, right? Muscle is strength. Muscle is protection against frailty. Muscle is healthy aging. So you could very well be gaining weight again, right? But not necessarily putting on muscle. So every cycle, you're actually gaining more fat, less muscle, more fat, less muscle. So you end up at the end of years and years of doing this of like large, but not necessarily got the strength, right? And we all know there's larger people out there and you look at them and you're like, you are strong. Like you are powerful. Like you're an athlete, right? But then there's larger people who are frail, right? And that's true of both smaller people and larger people. So those are the major things that I would caution people against. And that's when I hear this like long cycle, I'm like, how thick are your bones? How much muscle have you lost? That's why I do body composition analysis day one and every month. Because I in my practice, my patients, my menopausal patients, lose weight and build muscle. That is a physiologic feat. And they do so without me telling them when or what or anything. They do so by charting their own course with the best available evidence.
So what are the three things you want to tell our viewers?
Yeah, very concrete.
Concrete. What do you want them to take away?
I want them to eat. I want them to eat 3 times a day at least, okay? I want them to eat enough protein. I want them to not care about carbs and calories, focus on protein and fiber. I have a whole talk about how I do that. And then I want them to radically accept wherever they are right now. You can radically accept where you are and still want to change. You can do both of those things. But true change comes after. Like, I just am where I am. What's next?
Those are great takeaways. Dr. Ashley, you just gave us so much information.
Thanks.
I have to ask you, what makes you feel beautiful?
Well, the answer from your last guest was so good. I was like, oh, that's true. But actually, what makes me feel beautiful is like this integrity, like knowing that I'm doing the purposeful thing, right? So that's like the deeper answer. Moving my body, wearing clothes that I like, and like smiling, that kind of stuff.
Well, we've really enjoyed your visit, and I feel like we could have gone on for many more hours. Yeah. Thank you so much for coming.
Yes. Yeah. Thank you for having me.
Onyx is part of the crew, and he can get pretty hangry. So we got to make sure that we always have treats on hand to keep him happy, because we want TTOM to go well. So these little salmon recipe cat treats by a Canadian company are fantastic. I think you can tell. Thanks for listening today. This podcast is for entertainment and informational purposes only. The content shared here should not be considered professional medical advice. Always consult with a qualified healthcare provider for personalized medical guidance. We're here to empower and support you, but your health decisions should be made with your own medical team. Until next time, take care and keep thriving.